on to In our last sketch, we featured Hodgkin lymphoma at the dining hall. And now on to part 2, non-Hodgkin lymphoma. In case you need a refresher, here's the rundown. B cells pop out of the bone marrow and head to the germinal center of lymph nodes and other lymphoid organs. Here, they mutate, form a tumor, and subsequently start taking over other lymphoid tissues throughout the body. But enough with the science. Psh, boring. I know why you're here. You want to see the magic. Well, you're in for a treat because non Hodgkin lymphoma comes in a wide variety. Yep, you can find it all right here at Gurdon and Burkett's shop for magical oddities. This dimly lit, dust covered nook houses some of the world's most rare and evil objects. The shop has been run for decades by its owner and operator, Old Man Burkett. Less of a store, really, and more of a museum for the macabre and violent history of B cells and T cells. See that chessboard in the foreground? It's our symbol for lymphoid tissue. It's where the immune cells like to hang out. Those white archers are our recurring symbol for B cells. And those knights? Those are T cells, of course. And let the word knickknacks remind you of NK cells. Non Hodgkin lymphomas can arise from B cells or T cells, and rarely natural killer cells. B cell lymphomas are the most common and will be the main focus of this sketch, though we will see a T cell lymphoma pop up a little later. What makes a non Hodgkin lymphoma so non, rather than a Hodgkin lymphoma? Well, can you read? No owls allowed! Fly around and disturb the merch, not to mention that god awful creepy stare thing they do. That means no Reed Sternberg cells to speak of. Non Hodgkin lymphomas, or NHLs, have their own unique set of morphological and immunohistochemical features that we'll illustrate in a moment. Another classic difference between the NHLs and Hodgkin lymphoma is their pattern of lymph node involvement. Hodgkin likes to stay in a single nodal region, spreading contiguously from node to node. Non Hodgkin lymphoma, on the other hand, is classically associated with multiple lymph nodes involved in a non contiguous distribution. Kinda like those bats up there, just sporadically popping up. Thirdly, Hodgkin lymphoma likes to just stay in its little group of nodes. In non Hodgkin lymphoma, on the other hand, extranodal involvement is common. So we've scattered those B cell chess pieces away from the lymph node board. This shouldn't be too surprising though. Recall that secondary lymphoid tissues include not only the nodes and spleen, but also tonsils, GI tract, and even the lungs. Lymphoma cells can even migrate to non lymphoid tissues. Think CNS lymphoma. There are many different types of non Hodgkin lymphomas. They can generally be classified by whether they are low grade, known as indolent, or high grade, also known as aggressive. We'll arrange the low grade on the left side of the shop around this smoldering torch, and the high grade lymphomas on the right side of the shop near that brightly lit torch. Some of the most important indolent low grade NHLs we will discuss today are follicular lymphoma, embodied by that falling follicular sash, mucosal associated lymphoid tissue, or multilymphoma, which is a type of marginal zone lymphoma, and is symbolized by that pile of mucosal tissues. And finally, cutaneous T cell lymphomas, embodied by this creepy glory hand grabbing cutaneously, if you will, onto a helpless passerby. Don't touch anything. Some of the most important aggressive high grade NHLs we will discuss today are Burkitt lymphoma, diffuse large B cell lymphoma, symbolized by that diffusely large antibody archer, and primary CNS lymphoma, which can manifest in the brain, the meninges, the eye, or spinal cord. Which is why this mysterious brain in a jar is accompanied by some creepy eyeballs and a spinal cord. We will also briefly touch upon mantle cell lymphoma, which is considered an intermediate NHL. Unlike Hodgkin lymphoma, non Hodgkin patients are usually diagnosed after age 65, and more commonly in men. However, NHLs are the fifth most common cause of pediatric cancers. Pediatric lymphomas are typically high grade, while tumors in older adults are more likely to be low grade. Oddly enough, there are geographic associations with some of the lymphomas. We're going to highlight the endemic variation of Burkitt's lymphoma, which is most common in Africa and New Guinea. So, next to the Gurdon and Burkitt entrance, we've placed a cauldron etched with the contours of the African continent. New Guinea didn't quite fit, but you get the idea. Patients with NHL present very differently from one another depending on the type of lymphoma they have. Unless you are dealing with a high grade NHL, patients typically present with chronic nonspecific symptoms similar to Hodgkin lymphoma. Though children, remember, tend to present with more severe symptoms that rapidly progress. Let's get to the bottom of this with a few important questions you can ask your patient. First of all, you gotta ask about those lymph nodes. Just as in Hodgkin lymphoma, one of the most common presenting symptoms for NHL is painless lymphadenopathy. On this chess enthusiast over here, those white bats are supposed to represent palpable and enlarged lymph nodes. And he's smiling, so, pain free. Make sure to ask your patient how long they've noticed those enlarged lymph nodes, where they've noticed the nodes, and how many. With indolent lymphomas, it is common for lymphadenopathy to wax and wane, so ask about prior episodes. About 20% of patients will present with mediastinal adenopathy on chest radiograph. And it's important to keep in mind that a mediastinal tumor may be only one site of an otherwise systemic disease. Patients can present with chest discomfort, cough, or no symptoms at all. Up to 40% of patients present with B symptoms. These include a fever greater than 100.4 degrees, drenching night sweats, and unexplained weight loss of more than 10% of body weight over the last 6 months. These are all portrayed on this dude here who's purloining the potables. Definitely some fever happening there. Definitely a little sweaty. And yep, he's shrinking. That's weight loss for you. B symptoms are more common in more aggressive, higher grade types of NHL, which is why we've placed this thirsty thief on the right side of the sketch, next to that high grade torch. Pruritus is a less common symptom of NHL. However, the skin is a common extranodal site of NHL, and there's even a type of lymphoma called cutaneous T cell lymphoma, which may initially present as severely itchy skin. I've said time and time again, do not touch the creepy death hand thingy. Serves you right. What's the most common site of extranodal involvement, you ask? The GI tract, especially the stomach. While primary lymphomas of the GI tract are rare, secondary involvement occurs in about 10% of patients with early disease. Usually the stomach, but also the small bowel, colon, and rectum. Patients with GI involvement may present with GERD, epigastric pain, anorexia, and weight loss. Which is why old man Gurdon is looking, well, pretty girdy and in pain. That arm is pretty thin, too. I'd ask about weight loss. Next to old man Gurdon, we've drawn in that pile of mucousy tissues to remind you of mucosa associated lymphoid tissue, or multilymphoma, a rare primary lymphoma of the GI tract that is typically low grade. It is a subtype of marginal zone lymphoma, technically classified as an extranodal marginal zone lymphoma, or EMZL for short. Multilymphoma of the stomach can present with the GI symptoms we just described. Over on the high grade side of the room, we're going to see GI symptoms yet again, this time in kids. There are two forms of Burkitt lymphoma: the endemic variant found in equatorial Africa and New Guinea, and the sporadic variant found in the US and Western Europe. In the US, it accounts for 30% of pediatric lymphomas, and usually presents in the abdomen where it can cause massive ascites. So, next to the Gurdon and Burkitt entrance, we've drawn a kid inside one of the cauldrons, evoking the image of an abnormally distended abdomen, full of ascites fluid. Other presenting symptoms include bowel obstruction and GI bleed, illustrated by that keep closed sign, along with that bloody leak. The endemic variation of Burkitt lymphoma found in Africa usually presents as a large jaw or facial bone mass in children. Hence the bulge in his cheek there, as he tries some of the Burkitt brew. The sporadic variant of Burkitt is also associated with disease of the facial bones in about 25% of cases. Next up, the central nervous system. In a minority of patients, NHL can spread to the CNS, at which point it's dubbed a secondary CNS lymphoma. It can involve the meninges or the brain itself, causing anywhere from vague back pain and neck pain to focal deficits and seizures. Uncommonly, NHL can take the form of a primary CNS lymphoma, especially in immunocompromised patients. Primary CNS lymphoma in the brain can present as headaches, vision changes, motor impairment, and personality changes. All kinds of stuff. Ocular involvement can manifest as floaters, blurry vision, or decreased visual acuity that usually starts in one eye but eventually progresses to both eyes. Primary involvement of the spinal cord is pretty rare, but secondary involvement occurs in up to 6% of patients. A tumor typically first involves the tissues around the spinal cord and then invades the cord from there. This can result in spinal cord compression, presenting with loss of motor, sensory, or autonomic function. All right, let's dive into your patient's past medical history. Viral and bacterial infections may play a role in the development of several non Hodgkin lymphomas. We have already mentioned that EBV is important for the development of Hodgkin lymphoma because it is an oncogenic virus. And surprise, surprise, EBV is also implicated in the development of some non Hodgkin lymphomas. It's especially associated with endemic Burkitt lymphoma. In fact, pretty much every case of endemic Burkitt is EBV positive. And as you can see, the neon lights from Epstein's bar are right above our endemic Burkitt kid, who's still just chugging away there. Just like in Hodgkin lymphoma, HIV is a risk factor for developing NHL. AIDS related lymphomas are usually high grade. So we've placed our recurring sketchy symbol for HIV/AIDS, the white wizard hat from Sketchy Micro, on Old Man Burkitt over on the high grade side of the room. You remember that evil HIV wizard, right? AIDS related lymphomas are usually highly aggressive and are most commonly diffuse large B cell and Burkitt lymphomas, while CNS lymphoma accounts for about 15% of cases. The pathogenesis of NHL in the setting of HIV infection is not completely understood, but thought to be related to increased susceptibility to EBV infection, which is why he's holding a cold, frosty glass of Epstein's brew. Patients with congenital immunodeficiency disorders and post transplant patients are also at higher risk of developing NHL, which is why we've drawn in our recurring immunocrutch as well as a case full of transplantable organs. The increased risk of developing lymphoma is yet again thought to be associated with EBV infection, though this is probably only part of a multi step process. Diffuse large B cell and Burkitt are the most common variants that develop. Over on the other side of the room, we've got another infection causing lymphoma, and that's H. pylori. H. pylori is associated with chronic gastritis, which has been shown to cause the accumulation of B and T cells in the affected area. Over time, the cells get activated, proliferate, mutate, and bam, you've got lymphoma of the stomach. Specifically, a mucosa associated lymphoid tissue, or MALT lymphoma. At Sketchy, we represent Helicobacter pylori with a helicopter or other whirligig type device. And in this scene, this GI bug is symbolized by the fan blades above Gurdon and his mucousy MALT tissue pile. There are also certain autoimmune disorders that have been linked to some NHLs. These include systemic lupus erythematosus, rheumatoid arthritis, Hashimoto's thyroiditis, and Sjogren's syndrome. Lupus, for example, is associated with the development of diffuse large B cell lymphoma. The most common subtype of NHL in patients with Sjogren's is MALT lymphoma, especially of the parotid gland. Certain drugs and chemicals can also increase the risk of developing NHL, such as agriculture pesticides and Agent Orange. Additionally, assess for a history of chemotherapy or radiation treatment, both of which can increase the risk of NHL. Also ask about a personal or family history of hematopoietic cancers. All right, now that we have talked about the symptoms and risk factors for NHL, let's move to the objective data. First, the vitals. Specifically, assess for fever, a common B symptom in patients with high grade tumors. Most patients with NHL will present with painless lymphadenopathy, with nodes that are smooth and firm, just like the chest piece being palpated by this kid's bat friend. A complete lymph node survey should be performed on all patients suspected to have lymphoma. No cutting corners here. Besides checking the standard lymph node sites, take a look in the mouth. Waldeyer's ring is an area of lymphoid tissue in the throat, which encompasses the tonsils, base of the tongue, and nasopharynx. Signs that this area is involved include enlarged or asymmetrical tonsils, as well as preauricular adenopathy. And remember that chest x ray? Mediastinal lymph node involvement is common. In up to 8% of patients, a bulky mediastinal mass presents as superior vena cava syndrome. In this syndrome, the mass lesion blocks venous return, causing dyspnea, as well as swelling and erythema of the head, neck, and arms. Hence the red face of Limpwick over there. Dullness to percussion, as well as reduced breath and lung sounds, are signs of pleural and or pericardial effusion. Obstruction of lymphatic vessels can also lead to chylothorax. And remember that the liver and spleen contain lymphoid tissue as well. It is common for hepatosplenomegaly to occur with low-grade non-Hodgkin lymphomas. Rash and pruritus can occur in patients with NHL, but these presentations are less common. Mycosis fungoides is a unique hypopigmented rash consisting of patches and plaques that usually appear on the trunk and can be the initial presentation of cutaneous T-cell lymphoma. With the complete neuro exam, you can assess for possible CNS involvement or cord compression. Primary CNS lymphoma can initially present in the eye, with mostly posterior ocular involvement. A slit lamp exam can reveal uveitis, retinal hemorrhage, or retinal detachment. Oof, man, it seems like we checked everywhere. By the end of your physical exam, you may have an unclear picture of exactly what's going on. Let's check those labs. Occasionally, lymphomas will present with a combination of anemia, thrombocytopenia, leukopenia, or even pancytopenia. All kinds of emias and enias. These cell count disturbances are caused by invasion of NHL into the bone marrow, hypersplenism, or immune destruction. Aggressive tumors such as Burkitt lymphoma and diffuse large B-cell lymphoma can cause elevations of serum uric acid at presentation, represented by these crystalline shards entering the shop. Hyperuricemia is usually not severe enough to cause gout or nephrolithiasis. However, during initial treatment of rapidly proliferating NHLs, such as Burkitt lymphoma, tumor lysis syndrome can occur, resulting in increased levels of uric acid, LDH, potassium, and phosphate, as well as acute gout and kidney stones. Burkitt lymphoma is also associated with spontaneous tumor lysis syndrome. Elevated serum lactate dehydrogenase is common with aggressive NHLs such as diffuse large B-cell and Burkitt lymphoma. It may be a sign of high tumor burden, liver involvement, or hemolytic anemia. About 15% of patients will develop hypercalcemia during the course of their disease. The mechanism behind hypercalcemia in the setting of NHL is probably multifactorial and includes increased production of calcitriol and PTHRP. Alright, let's move on to some diagnostic studies you would consider in a patient with suspected NHL. Just as in Hodgkin lymphoma, the most important and definitive way to diagnose NHL is with an excisional lymph node biopsy. Microscopy, immunophenotyping with flow cytometry, immunohistochemistry, and genetic studies are used to make the final diagnosis. All the B-cell lymphomas covered in this sketch commonly express the B-cell markers CD19 and CD20, which is why we've incorporated the Roman numerals 19 and 20 into the stitching of this rug. Mantle cell lymphoma likes to express the T-cell marker CD5 because it likes being a jerk like that, while cutaneous T-cell lymphoma commonly expresses T-cell antigens such as CD2, CD4, and CD5. Let's look at Burkitt lymphoma first. This NHL arises from germinal or post-germinal center B cells. The pathology on lymph node biopsy will show a classic starry sky pattern. This pattern is composed of benign macrophages as the stars dispersed over a basophilic tumor cell sky background. Genetic studies will show a T814 translocation, which means a switching of loci between chromosomes 8 and 14. This causes a rearrangement of the MYC gene on chromosome 8 and overexpression of the MYC transcription factor, resulting in increased cell metabolism, growth, division, and cell death. We'll come back to this mantle a lot to illustrate the specific gene translocations involved with each NHL. Notice the 8 design in the window of the Burkett shop, adjacent to the 14 shaped candles. Next, let's talk about follicular lymphoma, represented by that falling follicular sash on the fireplace. Follicular lymphoma is the second most common type of NHL. It arises from germinal center B cells. The lymph node biopsy pathology will show a bunch of follicles with tightly packed cells, hence the name follicular lymphoma. We tried to convey this follicular pattern in the fire. Flow cytometry will commonly detect CD19 and CD20. Again, B cells here, so not surprising. Genetic studies usually show a translocation at 1418, which results in the overexpression of BCL2. BCL2 is an oncogene that normally blocks apoptosis, so as you can imagine, overexpression of BCL2 allows malignant cells to live longer. Not ideal. Notice that the diagonal line made by this falling follicular sash connects the 14 candles with the 18 shaped fireplace tools. Next up, mantle cell lymphoma, which arises from both naive B cells and antigen experienced B cells. Lymph node biopsy pathology will show small monomorphic lymphoid cells. Flow cytometry will commonly detect CD19, CD20, and CD5, which is a T cell marker. Mantle cell lymphomas are typically associated with an 1114 translocation, which is why the mantle here holds the 11 and 14 shaped candles. This leads to rearrangement of the cyclin D1 gene. This gene is important in regulating the G1 phase of the cell cycle, so get ready for some uncontrolled cellular division. Next, diffuse large B cell lymphoma. This is the most common type of NHL. It arises from mature B cells. And as you might guess from the name, the lymph node biopsy pathology will show atypical large cells, represented by this large antibody Archer sculpture. Well, large compared to the standard Archer chess pieces we've featured throughout this sketch. Again, flow cytometry will be positive for CD19 and CD20, those prototypical mature B cell markers. And how about that malt lymphoma? Well, if you want to get a biopsy of the malignant lymphoid tissue in the stomach, it's EGD time, which we tried to convey with the light shining deep inside the throat of this creepy mask on the wall. Remember that H. pylori associated gastritis is thought to play an important role in the pathogenesis of malt lymphoma, and initial endoscopy will usually reveal signs of nonspecific gastritis or ulceration. This area is then biopsied for signs of cancer. Maltomas arise from post-germinal center marginal zone B cells. On biopsy, the pathology will show a polymorphic infiltrate of many different kinds of lymphoid cells, as well as reactive germinal centers. Remember, the normal stomach does not normally contain significant amounts of lymphoid tissue. Flow cytometry is positive for CD19 and CD20. Again, typical B cell markers here. But we don't just look for cancer cells, we also check for H. pylori. So we've added a dangly H. pylori bacterium to the fan here. As a little extra reminder, histochemical techniques can be used to reveal the presence of H. pylori in the biopsy specimen. If no H. pylori is found, active infection still must be ruled out with a urea breath test or fecal antigen test. Why are we hunting for H. pylori? Well, the treatment and eradication of H. pylori can actually cause regression of disease in most cases of localized low-grade maltoma. No chemo necessary. This treatment involves triple or quadruple therapy with antibiotics plus a proton pump inhibitor. Be sure to check out our PUD sketch for more on H. pylori testing and treatment. H. pylori negative patients and those who fail antibiotic therapy will undergo chemoradiation therapy tailored to the stage of their disease. which we'll get into in a moment. One of the more interesting NHLs is the cutaneous T cell lymphoma. The most common subtypes are mycosis fungoides and Sézary syndrome. Both of these disorders can cause rash and can be diagnosed with a skin biopsy. So we've placed another one of those biopsy grabber tools at his side. He's gonna need it. Besides biopsying the skin, local nodes in the blood can be involved as well. So, involved lymph nodes are biopsied and the blood is checked for malignant T cells using flow cytometry. Notice that we've added some circulating malignant T cells to this sanguineous cloak. Cutaneous T cell lymphoma has been associated with T cell receptor gene rearrangements. Just think of this misspelled sign here with the T in the wrong place. T cell receptor gene rearrangements can be detected using PCR. Lastly, let's discuss primary CNS lymphoma. If your patient is experiencing neurological or ophthalmic symptoms that we discussed earlier, the diagnostic test of choice is an MRI. So we've added our recurring MRI magnet symbol on top. The characteristic finding is a solitary periventricular lesion with sharply circumscribed borders, illustrated here by the vent on the floor collecting goo, periventricular, if you will. If no mass effect exists, a lumbar puncture can be performed to assess for neoplastic lymphocytes in the CSF. If cells aren't found in the CSF, then a brain biopsy is the diagnostic procedure of choice. HIV infection increases the risk of CNS lymphoma, and it's recommended that all patients receive testing. In fact, it is common for patients diagnosed with NHL to be offered an HIV test. All right, one more diagnostic test I'd like to mention. In patients with mediastinal disease who present with a symptomatic pericardial or pleural effusion, why not remove some of that fluid for them? Just like we saw in the setting of Hodgkin lymphoma, initial management of patients with symptomatic effusions typically involves thoracentesis to remove fluids from the thorax, paracentesis to remove fluid from the peritoneal cavity, or pericardiocentesis to remove fluid from the pericardial sac. These procedures allow you to collect fluid for cytology and diagnosis, while at the same time remove fluid to relieve respiratory distress. In patients with malignant diffusion and respiratory distress, or in patients with malignant diffusion and no easily accessible lymph nodes, this is also often the diagnostic procedure of choice. All right, once a diagnosis of NHL has been made, a PET-CT is performed for staging. Hence the fantastic PETS tome here, along with our recurring black CT cat. The PET scan measures 18F fluorodeoxyglucose, or FDG, uptake by tumor cells. The staging system for NHL is essentially the same as in Hodgkin lymphoma. We highlighted the diaphragm of this anatomical cat to remind you of the whole lymph nodes above and below the diaphragm thing. Check out our Hodgkin lymphoma sketch for all the details on lymphoma classification and staging. Now let's review a quick differential diagnosis for non-Hodgkin lymphoma. Hodgkin lymphomas, of course, should also be on your differential. Both Hodgkin and non-Hodgkin lymphoma can occur at any age and are differentiated based on lymph node biopsy. Also keep acute and chronic leukemias in mind, which can present with constitutional symptoms and lymph node involvement. Your tests of choice here are a CBC with differential, blood smear, and lymph node biopsy. A patient with painless localized lymphadenopathy without a history or clinical presentation suggesting malignancy should be worked up for infectious etiologies. A CBC with differential should be obtained, as well as laboratory studies based upon the patient's demographics and exposure history, a few of which are listed in the text. Some autoimmune diseases, such as lupus, can mimic non-Hodgkin lymphoma. ANA can be checked if an autoimmune disorder is suspected. And finally, prolonged fever without a clear etiology is an especially difficult dilemma. Fever of unknown origin may be evaluated with a range of diagnostic tests, assessing for autoimmune, rheumatic, infectious, and neoplastic etiologies. Again, a few common tests are listed in the text. Now let's summarize the clinical presentation of non-Hodgkin lymphoma in a sample assessment statement. Mr. N. Hodges is a 21-year-old male presenting with an intermittent fever and frequent night sweats. On physical exam, he has non-tender lymphadenopathy of his cervical and supraclavicular lymph nodes. A chest x-ray shows a large mediastinal mass. Given his age, presence of B symptoms, and mediastinal mass, the most likely diagnosis is Hodgkin or aggressive non-Hodgkin lymphoma. So you'd probably guess that because each type of NHL is very different, they each have different treatment. Well, you'd be right. The treatment varies depending not only on what type of NHL they have, but also on its classification and staging. The chemotherapy regimen that is most commonly used in the treatment of NHL is called CHOP therapy and consists of cyclophosphamide, doxorubicin, vincristine, and prednisone. For patients with a B cell lymphoma, rituximab may be added. Rituximab is a monoclonal antibody against CD20 antigen, which is expressed on B cells. As such, it is not useful against T cell NHL. Rituximab can be used alone but is more commonly used in combination with chemotherapy, called RCHOP, though in this scene we've dubbed this mystical axe the chopper. Primary CNS lymphoma, by the way, is not treated with CHOP therapy. Instead, methotrexate, dexamethasone, and sometimes radiation are the best combination along with rituximab for B cell varieties. Radiation can also be used as the sole form of treatment if the disease is in an early stage NHL. For later stages, it can be used in combination with chemotherapy or used for palliation. Just as in Hodgkin lymphoma, NHL can have similar complications with therapy, including infertility, radiation induced hypothyroidism, and secondary malignancies. Patients should have frequent follow up and monitoring for complications, with annual skin cancer screening and early breast cancer screening. The prognosis of each type of NHL is variable. In general, indolent types are not curable, but they have longer median survival times, whereas aggressive types are curable, but the cure rate is variable and they tend to have a worse prognosis overall. Other factors that affect prognosis include age, overall health status, stage at diagnosis, and certain lab test results. Whew, that was a doozy. Sum up time. Non Hodgkin lymphoma arises from a mutated B cell, T cell, or rarely natural killer cell. B cells are the most common. The presentation of NHL varies based on the type and area of involvement. In general, your high grade lymphomas include Burkitt and diffuse large B cell lymphoma, as well as adult T cell leukemia or lymphoma, which is not covered in this sketch. High grade lymphomas are more likely to present with a rapidly growing mass. B symptoms such as fever, night sweats, and weight loss, as well as elevated levels of LDH and uric acid. Endemic Burkitt is more common in Africa and New Guinea, and typically presents with a mass of the jaw or facial bones. Sporadic Burkitt is more common in the US and Western Europe, and presents with an abdominal mass, bowel obstruction, and ascites. Indolent lymphomas are often insidious, presenting only with waxing and waning lymphadenopathy, hepatomegaly, splenomegaly, and various forms of cytopenia. Examples of indolent lymphomas include follicular lymphoma and marginal zone lymphomas, which include MALT lymphomas. In general, patients with NHL will have painless peripheral adenopathy in about 2 out of 3 cases. About 20% of patients will have mediastinal involvement at presentation. Look for a mass on chest x ray, as well as signs of malignant diffusion or superior vena cava syndrome. Up to a third of patients will have a primary extranodal lymphoma at presentation. Patients with primary CNS lymphoma may present with headache, focal neurologic symptoms, seizures, or spinal cord compression. It can involve the eyes as well. The classic presentation is a periventricular mass on MRI. If there is no intracranial mass lesion, a lumbar puncture can be performed to look for malignant cells. The most common site of extranodal involvement is the GI tract. Patients with primary or secondary gastrointestinal tract lymphoma may present with GERD, epigastric pain, anorexia, and weight loss. In these patients, perform an EGD and get a biopsy. Treating H. pylori can cause regression of gastric malt lymphoma in cases of localized low grade disease. In all patients, important risk factors to assess for include immunodeficiency, autoimmune disease, family history of lymphoma, and history of chemotherapy. The typical first step in diagnosis is excisional lymph node biopsy. Staging involves PET CT, and the most common treatment regimen is CHOP R with or without radiation. That's it. In our next sketch, we're going to get crazy with plasma cell dyscrasias. Yep, those B cells are acting up again.